Assalamualaikum. I am Dr. Mymensingh, Assistant Professor, Department of Paediatric Surgery. Welcome you all to today's clinical meeting. Today's clinical meeting is on an interesting journal. The topic is Diagnosing Testicular Torsion before Pediatric Urological Consultation and Imaging, Validation of twist score. The meeting is chaired by Professor Lokman Chowdhury sir, Professor and Head, Department of Paediatric Surgery, and speaker is Dr. Raghu Nath Karmaker, Registrar of Paediatric Surgery. Now I would like to Professor Lokman Chowdhury sir to the dais and conduct rest of the session. Thank you.
এই বসন্তের গ্রীষ্মের সপ্তাহ রাত্রির ঝড় আর শুক্র সকালে সবাইকে সুস্বাগত। Today's topic is Diagnosing Testicular Torsion before Pediatric Urological Consultation and Imaging. Validation of the testicular workup for ischemia and suspected torsion is very important topic. Very important topic. Our today's speaker, Dr. Raghu Nath Karmaker, he passed MBBS from Shastha Medical College, 2017. He is fully graduated from Department of Paediatric Surgery, Mymensingh, under Bangladesh Medical University, 2026. Now he is working as registrar, Department of Paediatric Surgery, from 1st January of 2026. Now I request Dr. Raghu Nath Karmaker to present his journal.
Thank you, sir. Honorable Chairperson, Director, respected teachers, dear colleagues and interns, welcome to all and very good morning. I am Dr. Raghu Nath Karmaker, Registered Department of Paediatric Surgery, Community-Based Medical College, going to present today's journal presentation. With the humble permission of Chairperson, I would like to proceed my presentation. Title of the journal: Diagnosing Testicular Torsion before Pediatric Urological Consultation and Imaging, Validation of the twist score. This information was taken from Journal of Urology 2016 June, and volume is 195, issue number 6, and page was 1870 to 1876. These are the author, and this is a prospective observational study which was done at Department of Paediatric Urology from the University of Texas Southwestern Medical Center and Children's Health, Dallas, and which was from March 2013 to March 2015. Introduction. Testicular torsion is a pediatric urological emergency and occurs approximately 10 to 15% of acute scrotal crises. Early diagnosis is very important because as irreversible testicular damage can occur within 4 to 8 hours due to compromised arterial blood supply. Diagnosis of testicular torsion usually done by Doppler ultrasound imaging, but which may delay urgent surgical intervention. That's why testicular workup score was developed as a clinical tool and based on history and physical examination findings. In pubertal boys, testicular torsion causes sudden onset of pain, nausea, or vomiting, and the sign of swelling, tenderness, and high-rating testes are not specific. That's why Doppler ultrasound is often required to diagnose the testicular torsion. Twist score is a important clinical tool which is very important to diagnose the testicular torsion, and based on some score which is ranges from 0 to 7 and based on 5 clinical signs. These are among them swelling and hard testes are points 2, and absent premenstrual reflex, nausea, vomiting, high reading testes given score 1, and total score 0 to 7, which is interpreted by if score more than 5, that's require immediate surgery. If score 3 to 4, do color Doppler ultrasound, and if patient has a score less than or equal to, is just observe the patient. This study aims to validate the effectiveness of the twist score to enable early risk stratification and faster clinical decision making in emergency setting. Aim of this study. This study wanted to determine whether early assessment using the twist score in emergency setting. Materials and method. Data was retrieved from PubMed, Medline, Cochrane Library, the Wiley Online Library, Web of Science, and American Pediatric Urology, June 2016. Inclusion criteria. All boys from birth to 18 years presented to emergency room with the complaints of painful scrotum, abdominal pain, testicular pain or swelling, oiling gait are included in this study. And we exclude the patient if pain due to trauma, if the symptoms persist more than 1 week, and if history of testicular disease or surgery, if diagnosis of testicular torsion had already been confirmed to ruled out, and previously known testicular or scrotal pathology. This was a prospective observational study from March 2013 to March 2015, conducted at Department of Paediatric Surgery from the University of Texas Southwestern Medical Center and Children's Health Dallas, and Doppler ultrasound used as a gold standard tool. Data was analyzed by ROC and AUC curve to analyze the twist score, and cutoff value for low, intermediate and high risk groups were selected by maximizing negative predictive value and positive predictive value while minimizing the false positive and false positive result. Fisher's exact test, Wilcoxon rank sum test and t-test were also done to statistical analysis and compare the two groups. All collected data were entered into the REDCap database. All statistical analysis was performed using Stata version 12. In this part, I discuss the result section. Among the 316 patients, 115 did not meet the study criteria, and 47 among the 316 patients, 115 did not meet the study criteria, and 47 declined to participate, and 1 patient direct transfer to operation room due to high suspicious of torsion, and 2 patients without torsion did not receive ultrasound, and 1 patient refused ultrasound, and other had low clinical suspicion, ultrasound could not done. Out of 154, 128 patients selected for the study because 26 patients data was not available, and 44 out of 128 patients were diagnosed with torsion and surgically confirmed. In table 1 showing the demographic characteristics of the patients, patients with torsion were older and were more likely to be white or black, had higher tanner stage, and had lower median hours of pain prior to arrival. In table 2 shows twist score result. The twist score component and total score was 0 to 7. The median twist score for torsion patient was 6 and median twist score of non-torsion patient was 1. The twist score is used to predict testicular torsion. The ROC curve showed very good accuracy with excellent statistical analysis, where area under curve or 0.95. And patients were grouped as low risk, intermediate risk, and high risk. And no patients with score 0 had torsion, and negative predictive value were 100% where there is no disease patients. While most patients with score more than 6 had torsion, where positive predictive value 93.5%. 2 torsion cases with low score had already undergone manual retorsion before surgery. This is the ROC curve of twist score, where area under curve 0.9%, 95%, where confidence interval 0.91 to 0.98. In Tanner stage, where if patients 3 to 5, this is the high risk of twist score and positive predictive value 100% and sensitivity is 65.6%. In Tanner stage, if Tanner stage is low, the accuracy of lower and sensitivity is 70%. 2 high-risk patients without torsion were early Tanner stage and had torsion of the appendix of testis. This is the ROC curve analysis of twist score in case of Tanner stage group of patients, where higher Tanner stage AUC 0.95%, confidence interval 0.91 to 0.99. An ROC curve of twist score in Tanner 1 patients shows AUC 0.96%, higher confidence interval 0.91 to 1. Discussion. No torsion cases were missed or follow-up, and all operated patients had torsion or testicular ischemia. Ultrasound is commonly used to diagnose torsion with very high accuracy, but it may delay diagnosis by 30 to 60 minutes. Focus on history and physical examination to diagnose testicular torsion and reduce reliance on imaging. The twist score is simple and easy to calculate during patient's evaluation. In this study, 65.9% of torsion cases were identified with a high-risk twist score 6 to 7, with only 6.5% unnecessary surgery in compared to Barbosa's study. The best cutoff for high risk was 6 points. A score of 0 indicated low risk with a negative predictive value 100%, meaning no torsion cases were missed. Using twist score, ultrasound could be avoided in more than 50% of patients. And testicular torsion are usually bimodal of presentation, especially neonatal period and puberty. Diagnosis is more difficult in prepubertal children as symptoms may be not clear. In this study, 2 high-risk patients without torsion, Tanner stage 1 to 2, had torsion of the appendix of testis. In Tanner stage 3 to 5, the high-risk twist score had 100% positive predictive value, showing better accuracy. Twist score still works in Tanner 1 to 2, but it has shows less accuracy. Therefore, ultrasound should be considered to confirm the diagnosis. Using twist score by emergency room by doctors and triage nurse may speed up pediatric urology consultation and surgery. However, more research is needed before this approach is used routinely. Limitation of this study: sample size is very small sample size to reduce the reliability of conclusion. Poor follow-up of non-torsion cases, possible misclassification, no consideration of symptom duration, and does not include the pain severity as a clinical indicator is missing and shows the selection bias. Conclusion: twist score is a simple, useful, and highly predictive clinical tool to assess the risk classification of testicular torsion. This score helps to determine the Doppler ultrasound is needed and when urgent surgical exploration should be performed. Take-home message: twist score can help early diagnosis and faster management of torsion. Thank you.